Today I'm going to talk to you about routine use of Ibex Prostate AI solution for primary diagnosis of prostate biopsies in clinical practice in our institution. As most of you know, UPMC is a huge healthcare provider but also insurer that is based in Pittsburgh, Pennsylvania, currently operating 40, or at this point maybe more than 40, academic, community, and specialty hospitals, about 800 doctors' offices and outpatient sites, and employing more than 5,000 physicians. You can see the impressive international footprint of our institution on the right side, with currently institutions in Ireland, Italy, Kazakhstan, China, and most recently Croatia. Regarding us in the Department of Pathology, it is a center of excellence. We call it a COE, providing high quality and, as most US institutions, subspecialized state-of-the-art services. We have 18 clinical divisions. I'm in the genitourinary pathology division myself. And in total, 166 faculty members under the UPP, the University of Pittsburgh Physicians. The volumes we process are pretty big. You can see that we are receiving and processing annually more than 200,000 anatomic pathology specimens. The two-dimensional barcode is the key to connecting to our clinical system. We do have 8 Apereo 82 scanners and 2 GT450 scanners distributed in 7 sites. Essentially, we are scanning at this point 1/3 roughly of our daily volume. And this is not distributed across all these 7 sites I mentioned, but across 3 histology labs. The total scan time is approximately 1.5 minutes. And again, we have multiple indications for scanning slides, like, for example, post-sign-out index slides. But specifically for GU, all the in-house prostate biopsies, we do digitize. So how does Ibex Galen for prostate work? This AI-powered solution was implemented back in May 2022. We have the glass slides that are digitized, and the algorithm is clever enough to identify the cores, and not only identify the cores, but also identify serial sections, essentially as duplicates on the same slide. And then it provides the pathology with a series of heat maps, probability heat maps, regarding a series of parameters that we are interested in to incorporate into our pathology reports. Obviously, the most important is benign versus malignant. Then, if malignant, the Gleason grade, automated measurements, presence of perineural invasion, and also high-grade prostatic intraepithelial neoplasia. The initial study, external validation study, is a study in 2020 by Pantanovic et al. Dr. Pantanovic is our chairman right now, that was published in Lancet Digital Health. So let me take you over this table here. You can see 3 different colors for the cases. The ones with the white color are the ones that are called by the algorithm essentially benign. The red ones are called malignant. And then you can see that roughly 1/4 of the cases are called suspicious, so they have this yellow color. Let's go first into the likely benign cases. You can see that 99.3% of the time for cases that were called benign by the algorithm, the pathologist also agreed with benign. There were only 2 discrepant cases called benign by Ibex that ended up getting called malignant by the pathologist. But the important thing is that even in these 2 individual cases, the points of interest that corresponded to the areas of neoplasia, they were still getting to the pathologist through the algorithm. So that gives us a very high negative predicted value. It's 0.99. And then going to the second category, the likely malignant, the red color, you can see that in 98.4% of the cases, there was essentially agreement for malignancy between Ibex and our pathologists. Just 2 cases that were called ASAP, so atypical small acinar proliferation by the pathologist, and the real discrepancy was only in 5 cases, corresponding to 1.3% here. And these were, as you can see, with a double asterisk, mostly cases with florid atrophy-related changes, like, for example, post-atrophic hyperplasia. So with this in mind, we can see that the positive predicted value is also very high. It's 0.99. And then I come to the third category with the yellow color, the suspicious cases. This can go either way, of course, benign or malignant. In my short empirical experience, the benign cases are a lot of cases with partial atrophy in the prostate that are picked up as suspicious. So this leads me to my next point. With such a high positive and negative predicted value, I really trust the algorithm in my daily practice as a screening tool. I don't personally use it as a tool with the intent to diagnose, but as an excellent screening tool, which also helps me to better manage my cases, triage if you prefer my cases, because I will start my day with the suspicious cases, so I can order my PIN4 stains early before our cutoff time, which for UPMC is 11 a.m., so I can get back the stains as fast as possible and minimize the turnaround time for my patients. You can also see on the top the cancer detection had an area under the curve, under the receiver operating characteristic curves of 0.989 with a 95% confidence interval of 0.983 to 0.997, so the performance is really very impressive. Next, we go to the Gleason grading. You can see that roughly 2/3 of the cases had full agreement defined as agreement between Ibex and pathologists with regards to the prostate cancer grade group, the 5-tier system. And there was partial agreement in 28.6% of the cases, meaning a difference just of one grade group. Again, my very limited personal experience mostly tells me that these are cases where the pathologist, we might end up calling like 3+4 with a small maybe 4%, but the algorithm has maybe a little more conservative approach, calling it 3+3. The real discrepancy was less than 10% in this cohort. And real discrepancy, I mean at least 2 grade groups. The few cases I've seen were actually cases that there might be a small focus of 5. And what happened was that the algorithm called 3+4, but there was consensus among the pathologists for 3+5. So this would lead to a change from grade group 2, essentially to grade group 4 with some patient implications. But mathematically talking, if we look at the quadratic kappa, which is essentially a chance-corrected agreement metric, it's very high, it's 0.763. So if it's above 0.6, it's considered very fair. And even the interclass correlation coefficient is pretty high, it's 0.75, with a 95% confidence interval of 0.665 up to 0.81. Some other quality metrics, I would call them. So all the pathologists felt confident in providing an accurate diagnosis when they were reporting the slides with the addition of Ibex, as with reporting on the microscope. Productivity, you can see that everyone felt at least somewhat potential, that there is at least somewhat potential to increase the diagnostic efficiency with the use of Ibex Gallen. No of the pathologists actually find that the solution was difficult to operate. You can see that most people thought it was very easy to somewhat easy and some neutral. And with regard to the customers, the pathologist satisfaction, which is the user in this case, you can see that there was consensus. 100% of pathologists were satisfied using Ibex, particularly because it provides us those features that are very important for reporting in our prostate biopsy reports, like the Gleason grade, scoring, the perineural invasion, and the automated measurements, as we will see later. So these were some general ideas behind the algorithm, but let's see some practical examples, how I use it and my other colleagues in our daily practice. So when I log in the morning, first thing in the morning in the Ibex website, this is the screen I'm getting with, as we already discussed, 3 types of cases. Cases marked with no color, or if you prefer white color, which are called essentially benign by the algorithm. Cases with red color, called malignant by the algorithm. And cases with yellow color, which, as we already said, they are called suspicious. And again, with such high positive and negative predictive values, I really trust the algorithm for the negative and the positive ones. So I'm still gonna see the glass slide, but maybe I feel more comfortable. But my point here is that I will start my day with the yellow cases, the suspicious ones, again, so I can order my stains fast and decrease the turnaround time for the patients. So, for example, like some representative images from such a case. So, for example, you can see here and here that these areas are busy. And then when we turn on the cancer heat map, you can see how it highlights the areas of interest, the cancer areas, and it essentially gives you a probability heat map where the color ranges from blue, meaning low probability, to red, which means high likelihood. And another case of 3+3 here, you can see 2 foci adjacent here and here with neoplastic glands traversing the core from one side to the other. And when we turn on the cancer heat map, the 2 areas are highlighted as areas with high likelihood of cancer. And then a different feature, the Gleason heat map essentially here. So in this case, you can see that the upper part of the core is very busy, back-to-back glands, poorly formed, fused. while the rest of the core has also neoplastic glands. You can't really see it like here because it's a low power image, but more like a Gleason 3. And then when I turn on my heat map, this area with the green-yellow color corresponds to the area of Gleason 4, and the area with the blue color corresponds to the area of Gleason 3. So the algorithm told me that this is 4 plus 3, and I can actually better visualize it using the probability heat map. And you can see here on the bottom the probability heat map for the Gleason grading feature, ranging from blue, meaning Gleason 3, to green-yellow, meaning Gleason 4, to red, meaning Gleason 5. So now you can see all 3 images together next to each other. The first one is obviously the H&E. The second, actually let's focus first in the right side, is the cancer heat map. Red means high probability of cancer. And the middle one is the Gleason heat map, with the red-yellow color here, meaning that we are probably looking at a prostate cancer case with Gleason 5 and 4. And realistically, if we compare with the H&E here, you can see this area here, plus these areas here with poorly formed cells, either as single cells or small cords of cells infiltrating the prostatic stroma. So you can see like the cases next to each other, the images, how you can see the cancer heat map, and also drive you to the Gleason grading. Another feature that I personally find useful is the perineural invasion heat map. You can see in this area a nerve bundle and how the neoplastic glands wrap around it. And then on the right side, you can look at the perineural invasion probability heat map and how it highlights it. This I personally find useful in some cases where I'm pretty confident there is perineural, but for some reason I have trouble finding. So if I don't find it within the first seconds, I'm going to click the heat map and accelerate my work. And even a case with a smaller nerve bundle here, involved by neoplastic prostatic glands. And here, how it is highlighted by the use of the probability heat map. So this is a useful feature. This is also a useful feature in terms of efficiency in time, and trying to decrease the time per case. This is the measurement, essentially, function. So the algorithm actually gives automated measurements to us, but even if you don't trust the automated measurements for tissue length of the course or for tumor length, you can use like a digital ruler that is inside the algorithm and make the measurements yourself. So again, if I compare this to what I did as a resident, counting with a ruler, this is much faster and probably more reproducible on the long term. Are we there? Can we use it? I mean, we're using it at UPMC, but the thing is that we have a very, very big need, which is unmet, to have specific codes to facilitate the billing for the use of such AI tools in general. So right now, there are AMA CPT codes in an effort to capture the effort that is being put. I think in 2024, there were like 30 new CPT class 3 codes. And we do try to capture the work units, but there's no money flow from the centers of Medicare and Medicaid services right now, which is a little problematic, because although everyone in the US wants to ride the wave and adopt the new technologies that are boosting efficiency and decrease turnaround times, however, the costs can be prohibitive and an impediment on the adoption of these new technologies. So where are we going to the future? Many AI algorithms are developed for using pathology, and this is particularly evident, I feel, in these years. USCAP, where the majority of posters and platforms I saw were around AI approaches, but the reality is that only a small percentage of those will end up actually being used in the routine clinical practice. At UPMC Pathology, we are very actively engaged in integrating these AI efforts, the AI solutions, into our daily, real clinical routine, especially with our new chairman, Dr. Pantanovich. And a perfect example of such an effort and such a deployment is the use of Ibex Prostate, which is used at UPMC and helps pathologists to improve diagnostic accuracy and for sure physician confidence. And of course, AI and digital pathology in general can enable the implementation of a centralized laboratory approach. So at this point, I would like to thank both my faculty members, Dr. Deer, Dr. Quiroga Garza, who is together with us, Dr. Pantanovich, the previous fellows that worked on this important project, but also the people in Ibex that are in daily discussions with us in an effort to improve the whole process. And before stopping, I would like to share with you one of my favorite sayings by one of the giants of AI in this era, Andrew Ng from Stanford. Essentially, AI is the new electricity, and like the electricity transformed every single industry 100 years ago, the same thing we're experiencing right now. AI is literally revolutionizing every possible industry, even our industry, the healthcare industry. And I think that we should not hold unrealistic fears in our minds that it will take our jobs and it will remove us from the clinical practice, but we should try to understand it first of all, optimize it and use it in an ethical way, both for our convenience as pathologists, but most importantly, for the better results for the patient population. Thank you very much.